Arrhythmias. In this lecture, I'm going to go through a series of cases to illustrate the management of arrhythmias in the critically ill. The first case is a 32-year-old man who's been admitted with pneumonia, who suddenly develops a tachycardia. How should this be managed? The first step is to determine whether the rhythm has resulted in a clinical deterioration. At a heart rate of 153, it is likely that the SVT is contributing significantly to the clinical deterioration. The next step is to determine the urgency of treatment. The hypotension and failure of peripheral perfusion, reflected by the failure of the pulse oximeter to detect peripheral pulsation, indicates that the patient is shocked and therefore the arrhythmia needs to be treated urgently. The treatment, therefore, is DC cardioversion. Starting energies at 50 to 100 joules for paroxysmal SVT or atrial flutter, regardless whether a monophasic or biphasic cardioverter is used. For atrial fibrillation, start with 200 joules if using monophasic and 120 to 200 joules if using biphasic. Once cardioverted, further treatment consists of treatment of the underlying cause and correction of precipitating abnormalities. The second case is a 45-year-old woman who collapsed at home and then had a fit. Her GCS is 7/15 on arrival in hospital, and she's intubated for airway protection. Following a CT brain, she develops this arrhythmia. The rhythm strip, shown in green, reveals a broad complex tachycardia with an alternating axis, characteristic of torsade de pointe, and an arterial trace, in red, shows that she is essentially pulseless. The management is therefore the same as for VF. She should be treated with defibrillation, not synchronized cardioversion. Once a normal rhythm has been restored, check the corrected QT interval. This is often given automatically by modern ECG machines, but if not, can be calculated by dividing the QT interval in seconds by the square root of the RR interval, also in seconds. If the QTC is prolonged, the rhythm is torsade de pointe. If not prolonged, the cause is ischemic until proved otherwise. As always, it is important to identify and treat the cause of the arrhythmia. This slide gives more common causes of torsades in ICU patients. The management is to withdraw any precipitating agent, give IV magnesium, and increase the heart rate, and hence shorten the QTC, with isoproterenol or rapid ventricular pacing. If the QTC is not prolonged, polymorphic VT should be assumed to be due to myocardial ischemia. Catecholamines should be withdrawn if tolerated, and anti-anginal therapy given. Beta blockers, revascularization, and or intra-aortic balloon pumping may be particularly useful. If these measures are contraindicated, amiodarone or lignocaine may be helpful. Moving on to our third case. What sort of rhythm is this? It's a broad complex tachycardia in a stable patient. Not only is the BP normal, but the pulse oximeter is able to pick up each pulsation, suggesting that the peripheral circulation is not severely impaired. This could be due to VT or SVT with aberrant conduction. How do we distinguish between the two? The history may provide clues. For example, VT is more common if there is history of ischemic or structural heart disease, and there are a number of ECG criteria which can be used to distinguish between the two. Most of these require relatively complicated rules to be committed to memory, and the simplest approach is probably just to look for evidence of AV dissociation on the 12-lead ECG. This is revealed by the presence of capture beats, which are narrow complexes reflecting intermittent conduction of an impulse from the atria to the ventricles, and fusion beats, which are capture beats superimposed on ventricular complexes. Both suggest the rhythm is a ventricular tachycardia. Features suggestive of SVT are a history of previous aberrant rhythms, accessory pathways, bundle branch block, or rate-dependent bundle branch block, and slowing or abolition by carotid sinus massage. So how do we treat a stable broad complex tachycardia? First, decide whether the rhythm is SVT or VT, or if you are uncertain. If you are uncertain, treat with DC cardioversion or amiodarone. If you think it is VT, then look at the complexes and check whether they are all the same, i.e. monomorphic, or vary from beat to beat, i.e. polymorphic. In practice, you are unlikely to see a patient with stable polymorphic VT, as polymorphic VT rapidly becomes unstable. As I've already discussed polymorphic VT, I will not go through the treatment again now. For monomorphic VT, see if it is sustained, i.e. persists for more than 30 seconds. Unsustained monomorphic VT should trigger a search for a cause, including checking arterial blood gases, electrolytes, and the position of any central venous catheters, as well as looking for evidence of myocardial ischemia. If it is sustained, look for and treat any reversible cause. Otherwise, or if necessary in addition, treat with DC cardioversion, amiodarone, or anti-arrhythmia pacing. If the patient has a stable, narrow complex tachycardia, the first step in diagnosis is to decide whether the rhythm is regular or irregular. If it is irregular, then the rhythm is either atrial fibrillation or multifocal atrial tachycardia. If it is regular, then features that aid in diagnosis are the presence of flutter waves or abnormal P waves on the ECG, the response to carotid sinus massage, and the response to adenosine. The presence of flutter waves indicates atrial flutter. Termination of the arrhythmia by carotid sinus massage or adenosine indicates paroxysmal SVT, while the presence of abnormal P waves indicates multifocal or ectopic atrial tachycardia. Our patient has a paroxysmal SVT, and drug treatment will depend on LV function. Options for treating paroxysmal SVT in those with good or poor LV function are listed here. Our fifth patient has a stable, irregular, narrow complex tachycardia. Causes of irregular narrow complex tachycardia include AF, atrial ectopics, and multifocal atrial tachycardia, an example of which is shown here. Notice the multiple P-wave morphologies and varying PR intervals. Our patient, however, has atrial fibrillation. The treatment aims for atrial fibrillation depend on whether it is chronic, in which case the aim is rate control, acute, in which case we aim for both restoration of sinus rhythm and rate control, or paroxysmal, in which case we want to restore sinus rhythm and prevent a recurrence of AF. In all cases, we also aim to prevent complications. Drugs which will control the rate only include beta blockers, diltiazem, and verapamil, and in some cases digoxin. Note that digoxin is of limited use in critically ill patients, except those with AF associated with heart failure. Drugs which may result in pharmacological conversion to sinus rhythm, as well as rate control, include amiodarone, procainamide, and dibutylide. In patients who are in AF for more than 48 hours, consider anticoagulation to prevent systemic embolization. Use agents that may convert the rhythm to sinus rhythm with extreme caution unless the patient is anticoagulated. And give anticoagulation for 3 weeks prior to cardioversion. Our last case is a 78-year-old man with dizziness. His ECG tracing shows a profound bradycardia with a complete dissociation between P waves and QRS complexes. This has resulted in significant hypotension, and he clearly needs urgent treatment.
In the form of atropine, followed if necessary by isoprenaline and or pacing.
In addition, it is of course necessary to look for and treat the cause. In summary, for tachycardias, the key questions are, is the arrhythmia pathological and is the patient shocked? Treatment aims are to treat or correct any precipitants, control or abort the arrhythmia, and prevent complications. For bradycardias, the key questions are, is the patient shocked and what is the arrhythmia? If the patient does not respond to atropine, consider isoproterenol or epinephrine infusion or pacing.